All right, and with that awesome intro behind us, welcome to our Craniosynostosis series for management. My name is David, and I'm an education director here with the Medical Student Neurosurgery Training Center. And I'm just going to go ahead and share some introductory slides to kick us off here. All right. And apologies for the delay for those of you who tuned in at 8. We had a little bit of a technical malfunction there, but we are back up and running. So this is, again, our craniosynostosis block, our first block of the new year. And so we had our first session of overview last week. This week is our management session. On Valentine's Day, we'll be doing our journal club. And then we have our grand round session the week after that. So all of these will be starting 8 p.m. Eastern on Tuesday. Tomorrow, we have a great webinar with Ryan, and it's going to be about spine trauma in Africa, where Ryan's going to be talking to a surgeon at Cornell Weill and discussing that in more detail. And that's, again, happening tomorrow night. And we also have the Neurosurgery Journey webinar, which is live every Thursday at 7 p.m. Eastern. And in fact, this Thursday, we have the neurosurgery preclinical perspective geared towards M1s and M2s who are interested in neurosurgery. So if you're an M1 or M2 and you want to learn more, definitely check this out this Thursday. And we have our Brain and Spine Injury Service fundraiser for military personnel, veterans, and patients. And we are really dedicated to supporting all of those individuals. Our goal is to raise $15,000 by February 15th. And so we're going to be posting some QR codes and some links in our chat. And we have more information on our website as well. So please donate if you're able. And we have our YouTube video library, which has recordings from webinars like this one, as well as previous ones. And we have over 10,000 subscribers on YouTube. Definitely check that out if you're interested, and be sure to subscribe. All right, and then we're just going to get started here with our esteemed guest, Dr. David Hersh. Dr. Hersh is a pediatric neurosurgeon at Connecticut Children's in Hartford, Connecticut, and he is an assistant professor of surgery and pediatrics at UConn School of Medicine. After obtaining his undergraduate and medical degrees at NYU's combined BA-MD program, Dr. Hersh moved to Baltimore to complete his neurosurgery residency at the University of Maryland Medical Center under the leadership of Dr. Howard Eisenberg. Having developed a passion for pediatric neurosurgery, he went on to complete a pediatric neurosurgical fellowship at Le Bonheur Children's Hospital and St. Jude Children's Research Hospital in Memphis, Tennessee. His current interests include pediatric neuro-oncology, epilepsy surgery, and endoscopy. And Dr. Hersh also serves as a faculty advisor for the Brain and Spine Group and the Medical Student Neurosurgery Training Center, and we are immensely grateful to him for all he does for us. So without further ado, Dr. Hersh, the floor is yours.
All right. Thank you so much to David, and thank you everyone for the invitation to be here. Let me know if you're able to see my slides. There we go. Can you see me?
Yes, we can see you.
All right. I'm going to try that one more time and share my slides here. Can you see the slides?
Yep, we can see them now.
Okay. We'll give that another shot. So tonight, the goal is to talk about craniosynostosis management. I know that you had a great lecture last week giving you an overview of craniosynostosis. And so I'm going to move rather quickly through some of the introductory especially in the intro, but I'll stop at a couple of these to highlight some key points. I think you probably heard all of this last week already, but it's really important to understand the anatomy that we're talking about. There's two main fontanelles when we're born, one in the front, the anterior fontanelle, one in the back, posterior fontanelle, which close a bit sooner. And when we talk about craniosynostosis, we're really talking about premature closure of one or more of these cranial sutures, which are the growth plates of the skull. And essentially, if one or more of those close prematurely, you end up with very specific head shape abnormalities because the growth becomes restricted perpendicular to that cranial suture, but it continues at all the other sutures that are still open. And so depending on which of the sutures has closed, you'll end up with one of these several head shapes. And it becomes really important, when we talk about management, really the first step is making the appropriate diagnosis in a reasonable time frame. And I'll talk a little bit about why the timing is so important. And so pattern recognition, really picking up on some of these features and some of these phenotypes, becomes really critical in the office. What you'll hear and what you'll find as you go through training is that in the vast majority of cases, we can make the diagnosis based on physical exam alone and recognizing these various head shapes. And it's really only a minority of cases where we need to go on to get some sort of imaging of the suture in order to see whether it's open or closed. So here you have a great example of a patient with sagittal craniosynostosis with restricted growth perpendicular to the sagittal suture. So you end up with a very long and narrow head with compensation in the front, frontal bossing, compensation in the back, occipital bulging. And you can see several examples of that here. With metopic craniosynostosis, you have restriction of growth perpendicular to that metopic suture. So you end up with a very narrow forehead, and the phenotype is described as trigonocephaly because it really looks like a triangle from the top down. And you see you can have a very narrow forehead with hypotelorism. The eyes are close together. You have a very prominent angle between the frontal bone and the orbit. There's several different examples of that here. Each one of these cases represents a patient with trigonocephaly. And we really have to differentiate that from benign metopic ridging, which is a condition that we see very often because it can happen when the metopic suture closes normally. And the metopic suture is the exception. It's the only suture that does close normally during infancy, usually between 3 and 9 months of age. And when it goes through that closing process, you can develop some ridging along the suture. This top photo is a picture of a patient with metopic ridging. You can see that although in a frontal view, you would see they have ridging along that midline ridge, along the midline metopic suture. From a top-down view, they really have an otherwise normal head shape, as opposed to a patient with metopic craniosynostosis who not only has a ridge, but also has that trigonocephalic head shape with severe narrowing of the forehead. Here's a patient with coronal craniosynostosis. You can see that because of that restricted growth perpendicular to the suture, you end up with retrusion of the forehead on the ipsilateral side, compensation on the contralateral side where it protrudes forward, and you also develop this facial scoliosis where the orbit is pulled up and you get this asymmetry. Let me head back there. You get this asymmetry of the orbits in addition to the frontal bone itself. Keyboard is very sensitive tonight. Here is an example of lambdoid craniosynostosis, which is often the one that creates a lot of anxiety because it mimics a very common but benign condition called plagiocephaly, which occurs when you just have positional flattening of one side of the head. With lambdoid craniosynostosis, on the other hand, you actually have closure of the suture, restricted perpendicular growth, and we have a few mechanisms and ways of differentiating this from benign positional plagiocephaly. Mainly with positional plagiocephaly, everything gets pushed forward on the side that's flat. So you end up with this parallelogram shape on the top-down view, as opposed to with lambdoid craniosynostosis. Due to all the various skull base changes, you actually get a trapezoid turned on its side. From a posterior view looking from the back, you can see that with plagiocephaly, the ears are pretty symmetric, whereas with lambdoid synostosis, there's a tilt of the skull base and this windswept appearance. And so I'm moving through these pretty quickly because I assume that you've heard most or all of these last week. But I do think that before we can really talk clearly about management, getting an accurate diagnosis becomes really, really critical. Part of that diagnosis can be imaging in the right circumstance. We do try to avoid ionizing radiation when we can. And so ultrasound has been gaining popularity as a tool to very easily visualize those sutures. On the left is an example of premature closure where a patient had craniosynostosis. On the right, you can see that lucency and hypoechoic area where there is an open patent suture. All right, so with that very, very brief introduction, let's talk about actual management. So the first thing that really becomes critical in terms of talking to families is what is our goal, right? What are the goals of surgery? And there are a few goals that people will allude to and speak about when they're talking about craniosynostosis. The really number one goal that we emphasize certainly when I talk to families is the aesthetic outcome that we're looking for. So we're trying to help reconstruct the skull, and there are a variety of ways to do that to help attain a normal shape. And that's not to minimize this goal at all. It's a very important goal. We know that children who have craniosynostosis that goes uncorrected can have very severe skull deformities. And there are certainly a lot of psychosocial considerations that go along with that. And so the aesthetic outcome is a very important one that we try to keep very close track of. There are other potential goals, and you'll hear people talk about intracranial hypertension, the potential for developmental delays and neurocognitive issues in patients with craniosynostosis. There's a lot of controversy that surrounds really both of these points. We do know that a certain percentage of patients with craniosynostosis develop intracranial hypertension. It's a much higher rate in patients who have syndromic craniosynostosis, whereas in patients with single suture, non-syndromic craniosynostosis tend to have rates of intracranial hypertension in the range of 10 to 15%. Certainly, if they develop intracranial hypertension, it's very important to address that, but it's very difficult to predict ahead of time which are the patients who are going to go on to develop that condition. And so although it's something that we screen for and watch for and continue to follow patients for, it's not necessarily the main reason that I stress to families for putting all of these patients through surgery. Certainly when it comes to neurocognitive outcomes, there's even more complicated data in the literature, and it becomes very difficult to sort through. So here's some of the, just a sampling of the papers that are out there. There's many more that talk about the incidence of intracranial hypertension in single suture craniosynostosis. There's a variety of different rates that are cited in the literature. When it comes to neurodevelopment, you can see, again, just a small sampling of the many papers that are out there here. But the reason why it becomes such a complicated issue in my mind is because it's really a question of the chicken or the egg. And so many people have endorsed this belief that if the brain is trying to grow, which it does during the first 2 years of life, and there's restriction of growth because of a prematurely closed suture, obviously that could potentially lead to intracranial hypertension and therefore issues with brain development and neurocognition. The alternative hypothesis is, well, if there's something that's structurally going on with the brain in the first place, the growing brain is what gives signals to the overlying dura, and we see that here, to release growth factors and signals that then signal the bone above it to grow. And so we know that mechanical strain on the dura itself by the growing brain is very important for skull development. There's something that happens along the way that impedes that growth, and the brain does not put that force on the overlying dura, then you can imagine that you may not have that signal for growth across the suture, and you can develop premature closure. So one of the theories of metopic craniosynostosis is, well, if there's something going on with frontal lobe development, that may prevent the bone above it from forming normally. And it doesn't matter what you do to that bone, if you reconstruct the frontal bones and expand that space, you're still not going to be able to correct the underlying issue. So that's one part of the controversy. There's a lot of studies that are ongoing that are trying to follow these patients very closely over the course of many years to get a better sense of where things stand. Is there really a role for surgery in improving neurodevelopment and minimizing the risk of intracranial hypertension? The most important thing that I think you should all know at this stage of your training, and you'll learn more about this as you move along, but there's really two primary options, two primary categories that we think about when we think about all of the different surgeries that are available for craniosynostosis. Minimally invasive, often that's described as endoscopic assisted, and then the other category is open reconstruction. So the surgical philosophy of a minimally invasive surgery is that we're going to remove the strip of bone along the prematurely fused suture and then allow the brain growth that follows to help reconstruct and redirect the growth of the skull. This was one of the earliest surgeries that was done for craniosynostosis, a simple strip craniectomy, and unfortunately it wasn't very effective. It's developed this sort of resurgence in recent years, and it's become incredibly popular for a variety of reasons. And some of it is technological. We now have this endoscopic technology that allows us to work through small incisions, so it makes things a lot safer for the patient. And the second is this understanding that, if we just remove that strip of bone and leave things to natural history, we'll get suboptimal results. But if we guide the growth of the skull after that, we can actually direct which directions and which vectors it's going to move in using a cranial orthosis or helmet. So we can remove that strip of bone, release the plates of bone that have fused, and then using specifically designed helmets, we can say, all right, if it's a sagittal case, we're going to put slight pressure here and here. we're going to leave space here and here. And as the brain continues to grow and tells the skull to continue to grow, it will preferentially grow in this direction and overcome that previously long and narrow shape that we were seeing. On the other hand, with open reconstruction, all of the correction is happening at the time of surgery. So with a minimally invasive surgery, you don't really look that different at the end of the procedure. It takes months for that skull growth to take hold and to reshape the skull. Whereas with an open reconstruction, you have your maximal correction at the time of surgery. And oftentimes we even overcorrect a little bit, knowing that there can be some retrusion over time. In terms of incisions, with minimally invasive surgery, it's usually one incision. With sagittal craniosynostosis, many people use two small incisions. These are about 2 to 3 centimeters in length. They're behind the hairline. They heal very well. With an open reconstruction, we use a bicoronal incision, often a wavy sort of incision, which also usually heals very well, but it is a much bigger incision. And because of the amount of scalp dissection that takes place, there's usually a significantly higher amount of blood loss that takes place with open reconstructions. As a result, the transfusion rate is fairly high with open reconstructions, whereas it is really incredibly low with minimally invasive surgery. And in our own experience, the rate is lower than what I say here at 10%. With a minimally invasive surgery, it's usually a 1 to 2 day stay in the hospital. It's usually one night, whereas with open reconstruction, it can be anywhere from 3 to 5 days. So you can see that there are definitely these short-term differences, and for that reason, a lot of families prefer minimally invasive surgery. A lot of surgeons have, taken on these minimally invasive procedures into their armamentarium. That being said, there certainly is still a role for open reconstruction, and we'll talk about that. One of the key things that really plays a role in determining which patients are candidates for minimally invasive surgery versus open reconstruction is the age at which they present. So because with minimally invasive surgery, we're really relying on the growth of the brain to direct future skull growth, we need that surgery to take place at a point where the head circumference or the patient really is still on the steeper part of their growth chart. So we know that the brain and the skull grow quickly in the first 6 months of life, and then gradually that starts to plateau. And so most studies will cite 6 months of age as the cutoff for minimally invasive surgery. We do know that ideally it should be before 4 months of age if possible. On the other hand, we don't want the patient to be too young because we want them to be able to tolerate surgery and the small amount of blood loss that goes with it. And so everybody has a slightly different threshold. For me, it's about 5 kilograms of weight. I usually try to aim for about 2 to 2.5 months of age. There are some slight differences there across institutions, but somewhere in the 2 to 4 month age range is really ideal, going all the way out to 6 months of age. Once you get past 6 months of age, it's just that the skull is growing a little bit too slowly for the cranial orthosis to really direct the future growth and get the optimal results that you're looking for. And so when patients present beyond that time, that's when we really start to think about open reconstruction options for them. So here's the variety of surgical options that are out there for surgical craniosynostosis. In panel A, you can see the 2 small incisions that we're talking about for a minimally invasive endoscopic assisted surgery. So we can use that endoscope to actually look underneath the scalp and go from one incision to the other. And it's important to point out that we actually go past both of these incisions too. And so we really need the entire sagittal suture to be removed in order to adequately separate those 2 parietal bones. That means going all the way to the anterior fontanelle and going all the way to the posterior fontanelle to where it meets with the lambdoid sutures. And so we draw these 2 incisions a couple of centimeters away from each so that we can work between the 2 as well as in front of and behind them. In panel B, you're seeing a slight variation on that theme. So instead of relying on a cranial orthosis or a helmet after surgery to guide growth, there are some groups that are using springs to help keep pushing the bones apart along that vector, and most importantly, prevent the bone from refusing and fusing back across the midline too soon before we have achieved the head shape that we're going for. The main downside to this type of procedure is that it does require a second small procedure to remove those springs once you are done with your treatment. With some of the other panels here, for example, in panel D, you're seeing a similar concept. These are with percutaneous distractors. And so these are devices that come out through the skin that you can turn gradually day by day and gradually move the bones across and away from each other. And with some of these other procedures, you're seeing the open types of procedures. For example, in panel C, there's a larger amount of bone removal and with barrel staves. Here are some examples of patients who are being positioned for endoscopic assisted procedures. On the left, you have what's really one of the standard workhorses, which is the Sphinx position. That gives us access to the entire vertex, front and back. There are definitely some disadvantages to positioning like this, primarily when it comes to the airway. You can see why anesthesia might be nervous in a case like this, because they don't really have ready access to the airway. And if the patient slips a little bit, you can see how that might interfere. And so we really take a lot of precautions when we're positioning patients for this type of surgery. One of my partners, John Martin, had described a variation on that theme a few years ago, where he had actually started positioning these patients in the lateral position, still supine on their back, but there's enough neck mobility in most of these infants that they could really turn their neck in a almost 90-degree position to get access to the front and back of the head and really minimize those airway issues that I'm alluding to. Some great papers that came out of the Hopkins group, really nice illustrations here that show how these patients are positioned. Again, this is illustrating the Sphinx position using a specialized head holder, and then using the endoscope through these small incisions to look underneath the scalp. And in these figures on the right, in panels A and B, you can kind of get a sense of what it looks like when you're actually looking up at the screen and seeing that view through the endoscope. So you can get a great view of the underlying dura, the bone, the overlying soft tissues, and there's a variety of instruments that we use in order to remove that strip of bone. Most people describe a 1 to 2 centimeter strip of bone along the sagittal suture that should be removed. And then here in figure 3 is the final result. This is a nice view of the dura. You have to check to make sure there's no CSF leaks, which is very important. And you can see the edges of the bone to make sure that there's no ongoing bleeding. Here's a patient that we treated. You can see her pre-op top-down photos on the left. Low cephalic index, very long and narrow head with prominent frontal bossing. Underwent a minimally invasive endoscopic assisted sagittal suturectomy. And this is her 8 months later. You can see that with helmet therapy guiding the growth, she was able to achieve really nice biparietal widening. You really can't even see the incisions. They're hidden under this hair somewhere, front and back. And she achieved a really optimal outcome from a head shape standpoint and is doing very well. There are other options for dealing with sagittal synostosis, depending on the age of the patient again. In slightly older patients, we'll do something called a pie procedure, which was described by John Jane. This typically involves a bicoronal incision and removing bone on either side of the sagittal suture in a pie shape. So this is really the opposite of what we do with an endoscopic assisted surgery, where we remove this fused suture. In this case, that's the one thing that is left behind, and we're removing bone on either side of it. And essentially what this does, by removing this pie-shaped bone, we're removing bone along the coronal sutures, and sometimes we'll extend it along the lambdoid sutures too. And it creates a lot of flexibility in the bone itself. And so we can drill pilot holes in this part of the bone on either side of the midline, as well as up here. And we can use various types of sutures to bridge that gap and really pull that space closed. And so in one setting, by the end of that surgery, we've reduced the diameter in terms of width, and we've shortened the skull in terms of length. And so you can immediately achieve that head shape that you're looking for. Here's an example of what that bony removal looks like. There's all sorts of variations and modifications of the pie procedure. So this is one of those where some bone was removed along the lambdoid sutures as well. And here's a great example of the time frame, and really the improvement we saw was right away. But this is what the patient looked like pre-op, and here you can see a nice result 2 months later. You get immediate shortening of that AP diameter. When it comes to metopic and coronal craniosynostosis, there are some similar themes. And so with both of those, we have those minimally invasive endoscopic assisted options. Using small incisions, we can remove a strip of bone along that fused suture. We also have an open reconstructive option called a frontal orbital advancement, which allows us to remove the frontal bone and the orbital bandeau and reshape it and put it back. And so I'll show examples of both of those. Here's an example of a patient with Metopic Craniosynostosis. You can see that narrow forehead. This is a great example from David Jimenez's website. David Jimenez is a neurosurgeon who really pioneered the endoscopic technique back in the 90s, I believe. And you can see he's marked out the metopic suture and the limit of bone removal. And really, you can do all of that work through this small incision. Here's a video that we put together a couple of years back showing one of our patients with a Metopic Craniosynostosis, of course, with patient permission, family permission. And so you can see a slight modification of that incision with a little curvilinear shape to stay behind the hairline. Here we're making that small incision, underscoring the galea in either direction to make sure we get all the way back to the anterior fontanelle and all the way to the frontonasal suture, which is the inferior limit. Here you can see we're exposing the anterior margin of the anterior fontanelle. We're going to expose those bony margins in order to dissect the epidural space, which is what's happening there. Here there's already been a small craniectomy that can be extended in order to get that initial window. In this case, I actually used a lighted retractor to maintain visualization. So although we often use endoscopes for these cases, that's not always necessary. There are some variations. You can see the fused metopic suture in the middle, this malleable protecting the dura, and then the lighted retractor up top protecting the soft tissues. And then again, a variety of tools that you can use to remove the fused bone. In this case, I was using a diamond drill tip, which heats up the bone as it's being removed in order to minimize blood loss from the bone edges. And here I'm just showing a view of what you can see while I'm working. And then at the very end, you should be able to see, I'm going to pause the screen in a second. So where that suction tip is the nasal cartilage that has been unroofed, and that's intentional. So right over here is where that nasofrontal suture was. And I wanted to make sure that the metopic suture had been released in its entirety all the way down to that nasofrontal suture. And so by the time I'm done, I can see that, that top part of the nasal cartilage. And then the final step is to confirm that you're released by actually moving the edges of the skull and visualizing that there's good mobility there. So that's what I'm doing here. This is what she looked like 6 months post-op. So you can see nice widening of that frontal bone there. And she's done very well. Oh, gosh. Sorry, I'm working with a new laptop here, and the mouse is extremely sensitive. Just going to rewind a little bit there. All right, so that was our Metopic case. With a coronal craniosynostosis, again, we won't go through all of the details because it's really the same concept. You have a small incision. When I do these, I actually prefer to go parallel to the suture. Just in case this patient needs an open procedure down the road, I find that a horizontally oriented incision is a little easier to work into a bicoronal incision. But
Dr. Hersh?
Yes.
Sorry, I think you stopped screen sharing.
All right, let me try to bring that back.
Sure.
Sorry about that.
Perfect. Thank you.
You can see that?
Yep, we can see that.
Okay, beautiful. And so for those reasons, in this slide, it's showing a perpendicularly oriented incision, and I was parallel incision. But the underlying concept is the same. Remove that strip of bone that's fused and then use a cranial orthosis to guide therapy after that. Are you still seeing the slides, the open reconstruction here?
Yes, we are.
Okay, perfect. So this is actually a website that you can go to that will simulate a frontal orbital advancement. It's free, and it's a really nice way of practicing and rehearsing the different steps. And so, frontal orbital advancements, these open reconstructions, I find most centers will combine these procedures with plastic surgery and neurosurgery. We use a bicoronal incision. Again, a lot of us like this wavy incision because when the hair grows over it, it grows in those waves, and so it covers it a little bit in a more aesthetic way. We're usually performing these surgeries certainly older than those minimally invasive ones that we were just looking at. So at least 6 months of age, usually 9 to 12 months of age. And at least frontal orbital advancements are usually being done for metopic and coronal craniosynostosis. There are other types of open reconstructions and calvarial vault reconstructions that we perform for sagittal craniosynostosis, but we're not as worried about the forehead in those cases. This essentially allows us to reshape the forehead and the orbital rim, and it also expands the intracranial volume. And in the simulator that I was showing, they show you all of the different cuts in order to remove the frontal bone. And then working across the orbital bandeau, there's a series of cuts that we have to make across the sphenoid, across the lateral orbital rim, medial orbital rim, and across the nasal bone here. In terms of, step by step, we won't go through all the details today. I think this is a great topic for a cadaver lab and a simulation session to really look at all of these steps in detail. And understanding the 3D anatomy is really critical for understanding where you're going to come across safely. Having really good dural dissection and protecting both the epidural space as well as the orbital contents is really important when we're making these cuts. And again, here you can see another nice three-dimensional view of that. Here's an example of somebody who had metopic craniosynostosis. And so you can see their trigonocephalic head shape here. The orbital bandeau was removed separately from the frontal bone. Using a little strip of bone in the middle, they were able to recontour that orbital bandeau, give it a much more normal appearance here without that trigonocephaly, and then it was replaced. And here on the AO website, there are also some really nice figures that are showing the amount of advancements that we typically obtain, as well as the recontoured orbital bone here. In most cases, you'll see that we use resorbable plates and screws. And so in these age groups, we really try to avoid titanium because you'll find that as the skull continues to grow, the titanium can actually erode through the bone and into the dura itself. And so really what most people are using these days are these resorbable plates and screws in addition to sutures. So there's so much more that we could talk about. Really what I focused on tonight is non-syndromic craniosynostosis. There's a whole separate lecture that we could talk about in terms of syndromic craniosynostosis because there's a lot of different techniques that we have at our disposal. Some of those are the same ones that you've heard about tonight. There is a growing movement to offer minimally invasive procedures as long as it's at a young enough age for patients with bicoronal craniosynostosis and syndromic craniosynostosis. But there's a whole variety of pathways and algorithms that we follow depending on whether the patient has intracranial hypertension, papilledema. What are the main considerations? There's posterior vault distractions, which we didn't really talk about tonight. There's the frontal orbital advancement. Some groups prefer to start with one versus the other. And so that's a whole nother topic that we can save for another night. But I think take-home points for tonight should be that craniosynostosis can usually be diagnosed based on the physical exam alone. There are some cases where imaging can be helpful, but it doesn't have to be done routinely. Early diagnosis prior to 4 months of age is ideal because that's what offers us the greatest flexibility in terms of our management options. If we can make the diagnosis early, we can at least offer a minimally invasive procedure. Whereas if we don't make the diagnosis until after 4 to 6 months of age, we still have great options in terms of the open approaches, but we just don't have that flexibility anymore. In single suture craniosynostosis, the goals of surgery are primarily aesthetic. We certainly have to keep intracranial hypertension in mind and screen for that, but the impact on neurodevelopment remains very controversial and a topic of ongoing study. Whereas with syndromic craniosynostosis, there are much higher rates of intracranial hypertension. It requires a multidisciplinary approach. The goals of surgery are usually different. But in all of these cases, options include endoscopic assisted surgery, very importantly, followed by helmet therapy. And patient compliance is very important when it comes to that. But that's what allows us to harness that ongoing growth of the brain versus these open reconstructive approaches, which you've seen here tonight. So I know it was a little quick, but I think those are the highlights, and I'll be happy to save a few minutes here at the end for questions.
All right. Thank you so much, Dr. Hersh. Hopefully, I'm not lagging out here. But and if anybody has a question in the chat, please feel free to chat, and we will read them and answer those questions. So something I was wondering about, you mentioned the plate versus spring debate, and the springs could be helpful, but also you have to remove them later. What do you usually use? And if you vary, is there a certain situation in which you use the springs versus the plate, and why?
It's a great question. I find that there are certain centers and certain surgeons that really like using the springs for the reasons that I mentioned. They prevent early closure of that bone across the midline again. And so there are some centers that have become really big proponents of using spring-assisted surgery. I have not really adopted that in my own practice. I have found to have had good success with the endoscopic assisted procedures followed by helmet therapy. So that's always been my preference. But I certainly see the pros and cons of both.
Makes sense. And also, I was wondering, because a big point of your talk was also the aesthetic considerations for children and undergoing this procedure. Do you also work with plastic surgeons to accomplish this? And how do you counsel families on something like that?
So we work really closely with our plastic surgeons. We have two great plastic surgeons, Chris Hughes and Charlie Castiglione, and we have a great craniofacial team. What you'll find at most centers that have a focus on craniofacial surgery is that there will be a really large multidisciplinary team that is run by a craniofacial coordinator. And so there's a team coordinator who helps bring together plastic surgery, neurosurgery, ophthalmology, developmental pediatrics, ENT, speech therapy, and the list goes on and on. And so we meet routinely in clinic where all of these different groups come together and we all evaluate patients on the same day so that we can save them various trips to the hospital. And it really becomes an important team effort. What I find in terms of actually performing the surgery is that when it's in these younger age groups and we're performing a minimally invasive strip craniectomy followed by helmet therapy, that's something that we will usually perform on our own as neurosurgeons. Whereas with the older patient group who's undergoing an open reconstruction, we work hand in hand with our plastic surgeons in the OR. And we're usually involved in the approach and performing the epidural dissection, protecting the underlying brain, and doing the craniotomy and removing that bone. The plastic surgeons will then come in and help reshape it, and then we all put it back together. And so it's a little bit of a dance in the OR.
Absolutely. It seems like you definitely need comprehensive care for these types of pediatric patients. And even though there are a lot of cooks in the kitchen, it seems like it works out quite well that way, doing it with that interdisciplinary approach. Even just discussing patient's care gives it more attention, which I think is important.
Absolutely.
Something else I was wondering was, there are also specific genetic conditions that predispose to some of these craniosynostoses. I'm assuming by the point that a patient comes to you looking for surgical intervention, they know of that genetic predisposition or maybe the defect that occurs there. And so I was wondering, do you ever have to counsel patients, families, et cetera, on that type of thing?
It's a great question, and it's definitely one of the top questions on patients' families' mind, right? If they have other kids, do they have to screen them? What if they want to have future kids? What we find is that with non-syndromic craniosynostosis, there often are genetic mutations that are identified, oftentimes in the FGFR family, the fibroblast growth factor receptor family. And a lot of those mutations do end up being sporadic. And so they're not mutations that were inherited from the parents. With syndromic craniosynostosis, again, there's over 150 different individual syndromes that have been identified now. The two most common ones that you'll hear about are Cruzon and Apert syndrome. And there's usually other phenotypic issues that are ongoing, both in the craniofacial skeleton as well as potentially other parts of the skeleton. With Apert syndrome, most of those patients have syndactyly, so you'll see issues with the hands and feet as well. So with syndromic craniosynostosis, we find that the diagnosis is often made really early, and those patients undergo genetic testing early on. With non-syndromic craniosynostosis, a lot of those patients came in because either the parent or the pediatrician noticed that something just looked off about the head shape without actually having the diagnosis when they come into the office. And we're the ones who provide them with that diagnosis based on what we assess in terms of the head shape. A lot of them will then go on to get genetic testing. It's not universal, for a single suture sagittal craniosynostosis patient. I don't know that it's critical that they go on to get genetic testing. Certainly anybody with multi-suture craniosynostosis or known syndromic craniosynostosis, genetic counseling can be very important. And just like everything else, we have a dedicated genetic counselor who will work with these patients.
Absolutely. And yeah, it definitely is interesting that you would actually have to make the diagnosis in your office, which is something I didn't actually think going into this talk that would be the case. And actually, we have a question from Dr. Rad. I'm going to see if I can actually show it on the screen here. And which surgery is your favorite or most interesting of the 150 or so that you could do?
I'm assuming we're talking about craniofacial surgeries in particular.
I believe so.
All right, not neurosurgery in general. That's a topic for another night. But
Yes.
of all the surgeries that I do for craniofacial diagnoses, I think a minimally invasive sagittal synesthectomy is just my favorite surgery for all the reasons you would think. It's every surgery has risks, but it's a relatively straightforward procedure. It's quick. Patients go home the next day and they have amazing outcomes. And so it's hard to beat that.
Definitely. And I guess one last question I have for you is, in terms of cost to families for a procedure like this, are you familiar with maybe what the cost would be or whether a lot of insurances cover something like this?
That is a great question. The answer is insurance does cover it. The helmet therapy after the surgery is always an interesting question because people typically think about helmets in the context of plagiocephaly, where all the sutures are open, but because of positioning, one side of the head has become flat. And so you'll see a lot of kids who are going around in doc bands or helmets of various kinds to help reshape that flattening. And those helmets, depending on the state you live in and what insurance you have, may or may not be covered by insurance. At Connecticut Children's, we actually worked very closely with Connecticut Medicaid, called Connecticut Husky, to get these helmets approved when they're appropriate. So we used the Congress of Neurological Surgeons guidelines that were put out a few years ago to show the insurance officials that there are very reasonable indications and scientific indications for when a helmet would be appropriate. Whereas before there were a lot of denials that we were seeing, that has changed over the years. When it comes to craniosynostosis, I really haven't had that same issue. I have not yet seen a cranial orthosis denied after a surgery because I think it's very well recognized that it's an important part of the treatment algorithm, that it's medically necessary in order to achieve the goals of the surgery. And so I haven't had any issues there. Most of my patients are going through 2 helmets because their skulls are continuing to grow after the surgery. There are adjustments that we can make while that's happening, but at some point they usually outgrow the first helmet and need to have a second helmet made in order to complete their treatment. And again, I haven't had any issues, knock on wood, with insurance companies denying either the first or the second helmet. There have been a lot of, maybe not a lot, but there have definitely been a decent number of studies that are in the literature now. Matt Smith, who's now down at All Children's in Florida, he put out some great papers about the cost effectiveness of minimally invasive endoscopic assisted surgery compared to open surgery. The argument being that, okay, it's a smaller procedure, it's less time in the hospital, you're not using all those resorbable plates and screws, so that would lead you to think that it's more cost effective. But on the other hand, you need to wear these helmets postoperatively, and those involve multiple trips to the orthotist, usually every 2 to 3 weeks, and maybe that will add up and make it more expensive than a one-time open procedure. And he actually found in his papers that the minimally invasive approach is more cost effective than the open procedure. So not only is it a shorter recovery for patients with equal, if not better, aesthetic outcomes, it's actually also more cost effective.
Wow, just adding to the fact that that clearly is a far superior approach if you're able to do it and you have the resources. So that is amazing. And it's amazing that you also push the boundaries forward on making these plates a little bit more affordable under Medicare there.
Yeah, I'll just give you one disclaimer, which is that I'm a big believer in this minimally invasive approach. There are definitely surgeons who are out there, some plastic surgeons, some neurosurgeons who really are still, they haven't bought the story yet, and they know that open procedures work well, and that's what they've known all their lives and are comfortable with. And there definitely are people out there who do not think that minimally invasive surgery is the be all and end all of craniofacial surgery. And so just know that when you're talking to people, is that I think it has gained traction over the years. And certainly at our meetings, at our national meetings, we always have these point counterpoint debates. And it's always comical because they put up two people, one person to argue for, one person to argue against, but they're both leaders in minimally invasive surgery who have both published plenty of papers about the advantages of minimally invasive surgery. So I think that kind of shows us where the pendulum has been swinging.
That is really funny. And it's great that it adds to the academic discourse there in terms of these different approaches. But they also probably should select some other individuals who are maybe on the other end of the pendulum there.
Yeah, well, just harder to find these days.
Oh, yeah, I'm sure. So just I'm recognizing the time there. I want to be cognizant of just have one follow-up question from Dr. Rad. And that is, it was a follow-up.
Microdisc of craniofacial. Yeah, I think you always have these debates when new technology comes out, when more minimally invasive approaches come out. The question becomes, obviously, minimally invasive surgery has appeal, right? It has appeal to families. It has appeal to us as surgeons. It has appeal to the system from a, getting out of the hospital faster standpoint. The real question that you always have to ask when you're faced with these new approaches is, do they still achieve the goals of the surgery in an equal, if not better way? And so I think that question has been asked appropriately of minimally invasive craniofacial surgery over the years. And there's a really nice body of evidence now that shows that it is effective if performed at the right age range and if families are compliant with the helmet therapy postoperatively.
Definitely.
Great question.
Thank you so much, Dr. Hersh. We really appreciate your presentation tonight. I also wanted to give a shout out to Nikki, who's another education director who helped to put together this event. So we're very grateful for her work. And thank you everybody for tuning in. We would appreciate it if you liked, comment, subscribe on all these different platforms you're on, and tune in next week, Tuesday, and also for our shows tomorrow and Thursday. Thank you so much, everyone. Have a good night.
Thanks, everyone.
Take care.